Hi everyone, welcome to our Expert Perspectives podcast series. I'm Amy, I'm one of the co-founders, radiologist by background, and I am joined by Dr. Steve Borden, who's going to chat to us today about stones. Steve, do you mind just introducing yourself?
No. Thanks for Amy for inviting me. I'm Stephen Gordon, consultant urologist. I have an interest in prostate, benign prostate enlargement, HOLEP laser surgery for prostate cancer diagnostics. We also, for many years, looked after patients with kidney stones, and also look after patients who have an interest in male fertility. And it's an area that not all of urologists deal with.
Great. That's quite a lot. Thanks for joining us. So we're going to hone in a little bit on the stone work that you do today. And the idea of this is to give our audience, which are mainly radiologists, an understanding of what is useful in a radiology report for you as the referrer to read. So we all know that CTKB is a really common study, and there's I guess slight difference when it's coming from an AE or a non-urologist. There, patient might present annoying pain and they're looking to see if there is a stone. And then there is the kind of more complex work that you urologists do where you're planning surgery, planning different types of treatment and what to do. So if we start with the kind of really common kind, CTKB request. Patient comes in, undergoing pain. We get the request saying, is there a renal stone? What's helpful for you from that request?
Yeah, I think it depends on who's requesting it, because obviously when the patient's coming that way, it's most commonly coming from A&E. Yes, sometimes some primary care settings may be able to request CTs, but usually when the patient presents an acute pain, it's such a bad pain, they turn up in A&E, and it may be a urologist, but more often it's an A&E doctor arranging the CT. We're lucky, aren't we, that patient but lucky, but we're lucky that usually the symptoms of a passing kidney stone are pretty typical. And I think the importance now with CT is that we have most of the time we know in the acute event, there is you detect a stone, we know that that's causing pain, and it's a really good diagnostic test. But I think there's lots behind that, because sometimes you'll get requests from people with vague pains or pains of other, both sides or things like that. So I suspect there are other calcific densities that maybe phlebitis may be difficult to comment on or whatever. So we do look for, as urologists, we're very much keen on seeing if there's a stone, and if we think that is the thing that's causing the acute pain. So are there, is there hydronephrosis, hydroureter, and then the details about the stone.
That's interesting you said that. You picked up on one of our questions, which was about the calcific density. So I always put a Hounsfield unit in all of the stones I measure, partly because I've worked with you. I know some of the answers you work with. But why is that important? What difference does that make for you in terms of treatment planning?
Well, I think it also goes back to the days when before we did CT scans, and we used to do X-rays, and we did IBUs, and it would be very much, if you can see the stone on an X-ray, that's important, and sometimes that correlates with the Hounsfield unit. But also, you'll know that I'm a strong believer in using shock probe lithotripsy to treat stones, and for the radiographers usually who are delivering lithotripsy, yes, you can do it with ultrasound guidance as well, but in a ureteric stone, looking for ureteric stones, if you can see it on X-ray and then use an image intensifier to deliver the lithotripsy, that's where the Hounsfield units are important, or whether you can see it in the scalps is important. Because I think there was a study from Australia some years ago, which if you could see the stone on the scalp one, then you're going to see it's on a plain KU X-ray or image intensifier to allow it to deliver the lithotripsy. And we know that shock wave lithotripsy for acute stones, if you can deliver it quickly, is a really cost-effective way of treating such patients. So that's one of the reasons I used to think about Hounsfield units being useful, because you may not think to look in the scalp, and we also know that the very high density stones may not be successfully treated. So if you've got a 1400 Hounsfield unit stone, you're probably less likely to break it up. Having said that, the evidence certainly from Scottish literature was that it could still be beneficiary in those patients. So you wouldn't necessarily rule it out, but it can be useful. Of course, if you can see a stone easily on CT at 700 house units, you might be thinking, I'm not going to see it for lithotripsy, but you may also be thinking, what's that stone made of? Is it a uric acid stone? And we know there may be a different approach, maybe even a medical approach, a dissolution approach that may help that patient and dealing with their stone. So the Hansford unit does come in it's very useful when we're thinking about that stone event, but also preventing further stone events in patients.
That's really helpful. What other information do you want about a stone other than Hansford unit? I presume size.
Well, size is important, but what we're realizing, and a lot of the studies now are saying this is the volume of the stone is important, but is again, how do you look at your CT scan? Do you look at it in the conventional axial sort of slices, or do you look at the thin slices, 0.625 millimeters, or do you at 3 millimeter reconstructions? And actually, that by the time is important for measuring the Hansford units as well, because when you measure the Hansford units on the thicker slices or the reconstructions, it's a very different number.
Yeah.
And that can be relevant when you come to treat. But we will often see patients get very upset when we say, well, they told me it was a 4 millimeter stone, and I've been told less than 5 is more likely to pass. But you've told me you've looked on the sagittal or coronal image, and it's 7 or 8 millimeters long. The importance from a urology perspective, there was a great study done by urology trainees looking at those patients coming with acute colic, had CT scans, and they looked at things like hydronephrosis, hydroureter, the size of the stone, and if you have practice to come up with an algorithm to see, predict whether the stone would pass or not. And in that, they talked about measurements of the stones in a very modern study using UK sort of patients. And it's a very good predictive tool to know the size of the stone.
So for the radiologist listening, do you want just the biggest measurement, whether that is axial or
I think that if you're going to do one measurement, yes.
Yeah.
It's purest in urology with say million volume.
Yeah.
But it's a bit like prospects. How will you measure that volume? What's your fudge factor? Is it level? Is it bullet shaped? Is it stone shaped?
Yeah.
And actually, I suspect, having measured lots of prostates in my time, that probably that's where AI will be able to suddenly run through a scan and suddenly say, well, the bottom of your stone is this, and the chest is this. And actually, that will take that bit of the radiology bit.
I've been asking for to build that AI talk so long.
And I can look up, I'm starting to use AI now, and it is definitely, it will make so much of our lives that we can fight doing, or we can to. Those 3 measurements will be there, and then you will just look at it, and it will be.
Yeah.